Hello, everyone. Welcome. My name is Gloria Chiu, and I'm so happy to be here with you all. Good morning, good afternoon, or good evening, depending on what time of the day it is where you are. The awesome thing about technology today is that we're able to engage and connect with each other at all times of the day and all over the world. So I'm really grateful for this opportunity to be here with you today with this joint collaboration between the Global Specialty Lens Symposium and CLASS, Contact Lenses of the Americans Specialist Symposium. So first, let me introduce myself. Again, my name is Gloria Chiu. I'm an optometrist and I practice at the USC Roski Eye Institute at the Keck Medical Center of the University of Southern California in Los Angeles. And I have been an optometrist there for a little over 12 years. I've been able to work with a bunch of wonderful corneal specialists and focus particularly on fitting specialty contact lenses, particularly scleral lenses. So our title for today, the topic for today, will be Keratoconus, scleral lens considerations and management. So let's start with an overview of keratoconus. As many of you already know, this is a corneal disorder with central thinning and steepening. Comes from the Greek words kerato, meaning cornea, and conus, meaning cone. It's a bilateral condition, but oftentimes asymmetric. So if you look at these photos on the right, the top set of eyes, you see one eye, the right eye, that looks very normal. This patient sees pretty much 20/20 uncorrected. In his left eye, however, you see significant central corneal scarring. With a scleral lens, this eye sees, believe it or not, about 20/25, which is crazy. Kind of speaks to the power of scleral lenses. And so you see an asymmetrical appearance here. However, on the eyes below, you see moderate central corneal scarring in both eyes. This patient is in his 70s. He's had keratoconus for many decades. And his best corrected vision is about 20/50 in each eye, given the scarring and some cataracts. So with scleral lens wear, it's not perfect, but he's functional. This is a progressive condition that starts out typically very mild or non-detectable and can become very severe. And it's non-inflammatory, so typically not associated with neovascularization or keratitis. The onset is in the teens or puberty when the hormones are changing. And the prevalence and incidence, so just a quick review, prevalence refers to the proportion of the population who has this condition or keratoconus, and incidence refers to the number of new cases during a specific period of time. So these figures vary with geography, ethnicity, as well as the study that's reporting this data. And I want to stress that the diagnosis of keratoconus is often from optometrists. It's not from pediatricians looking at infants or toddlers. It's typically not primary care physicians because it's hard to detect early keratoconus without the proper tools. And it's typically not ophthalmologists either because they're not primary care physicians like we are as optometrists. So etiology of keratoconus, is it nature or nurture? Well, it's a little bit of both. So there's definitely a genetic component. There's a familial inheritance, which can be autosomal dominant or recessive. There's also an environmental factor. So in terms of UV exposure, well, UV is a source of reactive oxygen species, and excessive exposure to this UV light can lead to oxidative damage to the cornea. And atopic conditions, well, atopy is associated with a heightened immune response to common environmental allergens. And atopic conditions include asthma, eczema, hay fever, allergic conjunctivitis. And it's interesting that many keratoconus patients have these conditions. And contact lens wear. Well, if you have rubbing on the cornea due to a particularly flat, tight, or poor fit, you can be causing microtrauma to the epithelium, in turn increasing inflammatory mediators and leading to progression. In terms of risk factors, there are several. One is family history. So we definitely know the genetic component. And I definitely have patients in the same family with this condition, and we'll go over a few examples of that within this talk. Age. Younger age is a higher risk factor for keratoconus progression detection. Keratoconus in itself. And eye rubbing, again, this motion with not just like light brushing of your eyelids or lashes, but heavy, deep knuckle rubbing. This is the type of infliction in the eye that can increase inflammation and possibly lead to more progression. And I do want to touch upon genetic testing that is available now for our patients. It's there's a test called Avogen test, and it's made by a company called Avellino, actually based in California in the United States. And this test quantifies the risk of keratoconus and other corneal dystrophies as well, caused by gene variants. So this is a very helpful tool for early detection and helping to make decisions. It may also be an interesting screening tool for patients possibly interested in LASIK. As we know, keratoconus is contraindicated in LASIK and certain refractive surgery. So maybe a good tool that we can consider using now that this company has relaunched it this year in 2021. So let's take a look at this chart here, the reported incidence and prevalence of keratoconus. So you can see several studies listed here, and the prevalence ranges from close to zero, actually, 0.05% in a study that came out of the US, and up to 4.79% in Saudi Arabia. So depending on the country, how the study was conducted, the prevalence can range, but generally I would say it's about 2% or so. And in this study that you can see this graph on the right titled Incidence and Prevalence of Keratoconus in Denmark, this is a really interesting study that shows here that the incidence of keratoconus has actually increased 2 to 3-fold in the last 15 years or so. And the authors of this study believe that is true, one, due to better diagnostic tools to help detect early keratoconus, as well as the availability of cross-linking. So with this procedure that we'll talk about today, with it available, more doctors are referring patients with early keratoconus who are good candidates for cross-linking for this procedure, and hence their cases are being noted. So let's talk about how to make the diagnosis. So we have a lot of wonderful tools in our clinic. The first, pretty much everyone has, is a phoropter and a retinoscope. So when you're scoping your patients in keratoconus, you may often see a scissoring motion. So instead of seeing your bar go with or against motion, you're going to see scissoring with the two beams coming together. That is a sign that there could be some distortion in the cornea. Sorry, I needed a quick drink there. And also, when you're refracting your patients, if you're unable to refract your patient to a crisp 20/20, that is a red flag that something is going on either in the cornea, in the media, or even in the retina. With keratoconus, however, you may get large amounts of SIL, fluctuating, difficult endpoints from your patient. Finally, the slit lamp is very important. We're looking directly at the cornea with this microscope. Things you want to look for are central thinning that can often be appreciated best with the bright, thin optic section where you can scan through and see the thinning in the center of the cornea. Also, you may see what we call striae, and you'll see these little vertical lines centrally, and those are essentially stretch marks because the cornea is losing its normal organized structure. You may also see a brown circle on the cornea or even part of a circle, and those are iron deposits at the base of the cone, and this is called Fleischer's ring. As keratoconus progresses, you may then see more advanced signs such as corneal scarring or Munson's sign, where you see the lower lid bulging out when the patient looks down. We also have other tools such as a topographer or a tomographer, and we are going to talk about that next here. So some helpful equipment, in addition to our phoropter, retinoscope, and slit lamp, a corneal topographer. So this maps the front surface curvature, and it's a Placido disc-based instrument. Then we have the Schlumpflug tomographer, which gives us 3D imaging. It maps the front and back corneal surface and gives us an overall thickness of the cornea, which is really great. So it gives us this global pachymetry reading, because if the cornea is thinner than average, that again is a red flag that you're looking at a patient with keratoconus. The average cornea is about 530 to 550 microns. So if you're seeing central corneal thickness maybe less than 500, maybe start to get a little suspicious. The anterior segment OCT, which was first described in 1994 and initially used for the retina, has many, many applications now and gives us high resolution cross-sectional imaging. Another tool that we don't want to overlook is the autorefractor. Now, although it does not give us beautiful maps like the topographer or tomographer, it can give us very helpful numbers. First of all, if you're seeing very unusual refractive error, high sphere, SIL, or errors, it could be a sign that there's distortion on the cornea. You also want to look for asymmetry, one in the cornea itself. If you're seeing, 3 or 5 or more diopters difference between the flat and steep K, that is a sign that something's going on. Second, asymmetry between the two eyes. So if one eye has Ks of 43 and 45, and the other eye has Ks of 45 and 50, there's some asymmetry there that we want to see. Why are the corneas different? And although you can miss the inferior steepening that you see classically with topography or tomography, unusual numbers may be a hint that you should conduct further testing. So let's get to kind of our topic here of scleral lenses and contact lenses in keratoconus patients. So we all know that our keratoconus patients need and want to see better. It's our job to prescribe glasses. This photo of these glasses here on the right, it's interesting. These are glasses from a keratoconic patient of mine who got these glasses online. They're lenticulated and they're -20 in both eyes. Not surprisingly, she didn't see very well with them. Also, we want to offer contact lenses to our patients. Today, we have many options, and these options are continuing to expand, which is very exciting. So we have our simpler contact lenses include spherical and toric soft lenses. Then we have custom toric and custom soft lenses. We then have hybrid lenses with a rigid center and soft skirt. And we have RGP lenses that are still very valuable, although they're not as popular and hot and sexy as scleral lenses seem to be. RGPs can really work well for the right patient. They're easier to handle. They tend to cost less. The application and removal can also be a little bit easier for some patients. And here's an example of an RGP on a keratoconic patient's eye. And you see kind of an irregular pattern just due to the central scarring. And I did get burned on this case. I tried to convert this patient who had been wearing RGPs for decades actually to try scleral lenses. In the end, she just didn't like them as much as her RGPs. So we ended up going back to RGPs. We have piggyback lenses where you use an RGP on top of a soft lens, kind of like training wheels. And then we have scleral lenses. So our hot topic for today. Scleral lenses come in all shapes and sizes, as you can see in this photo. And even over the last 5 years, we've been able to learn and grow so much with technology. We have image-guided fittings now with the profilometer, and we even have impression molding options, which is allowing us to fit scleral lenses around much more irregularly shaped eyes with maybe glaucoma tubes, tube shunts, blebs, maybe very elevated pinguecula. So we're really not letting much stop us now today in terms of getting a good scleral lens fit. So your patient now is wearing scleral lenses. Yay! So let's take a look at the pros and cons of this modality. In terms of the pros of scleral lenses, generally we have better comfort. We're not rubbing on the cornea anymore because it's larger. It tends to be much more stable. So less lens dislocation as with RGPs and less lens loss. And you tend to also have more stability in the vision if you have a good tear film. Now, in terms of the cons, the true keratoconic corneal shape does emerge. So if a patient had been wearing RGPs, expect a transition because the RGP does touch the cornea and can leave a bit of a corneal molding effect. Patients may notice some difficulty with spectacle wear, especially if they're transitioning between lens modalities. And maybe they did fine wearing glasses with RGPs because it kind of held the cornea in shape, but with scleral lenses, they might struggle with glasses a little bit more. Tear film is a big issue with scleral lenses. The fluid reservoir that is required can become cloudy if you don't have a precise alignment or the patient has a lot of debris and oil in their tear film. This may actually force you to consider other modalities for them. And there's all kinds of fitting challenges. You know, about 15 years ago, when very few people were fitting scleral lenses, it was a new thing. And we didn't know as much about challenges. Now there's a lot of reports in the literature discussing hypoxia, epithelial bullae, oxygen issues, graft issues, wetting issues, debris issues. So there's a lot of issues, and these examples here on the right, particularly on the bottom, just show how important the tear film is. This is a patient with keratoconus with super, super dry eyes and very bad allergic conjunctivitis. And he builds these plaques on the front surface of his lens within a short period of time and has to just keep continually ordering new ones every 6 months to a year. So aside from vision, we as optometrists also need to make sure we're monitoring their keratoconic condition itself, the disease itself. So they may be asking you, doctor, are my eyes getting worse? It's important that we follow up every 6 to 12 months with our patients, particularly the younger ones. And when I say younger, I mean those in their teens and 20s, because typically keratoconus progresses around that time, tends to stabilize in the 30s, and in the 40s, in some of the studies, it's shown that even with any progression, it tends to not be clinically relevant anymore. So we need to make sure that we're monitoring the cornea and eye health, looking at refractions, is it changing? Looking at best corrected vision with both glasses and contacts. Corneal thickness, is it getting thinner at all? The corneal profile, is it becoming steeper anywhere? And don't forget to look at their lid health. As we know, keratoconic patients are more prone to developing atopic conditions, such as allergic conjunctivitis. So if you see papillae, if they're rubbing, consider prescribing them topical anti-allergy medications. There's a lot of great over-the-counter options these days because we don't want them to be rubbing their eyes. Also, floppy eyelid syndrome is very common in keratoconic patients, so make sure to lift the lid, see if it's floppy, and if it is, ask potentially about snoring, sleep apnea, because there is a relationship between floppy eyelid syndrome and sleep apnea. So kind of one more thing that can help you make sure that you're managing your patient, their whole patient, not just their eyes. Also, make sure to take the scleral lens off during your examination. Obviously, it's difficult to monitor all these parameters without taking it off because scleral lenses could potentially be masking progression. If your patient sees 20/25 despite significant scarring and thinning, they may think that their eyes are just fine, when in reality, they may be thinning further or developing more scarring. If they see well, they may not think that anything's wrong. So make sure to take it off and monitor the parameters on their cornea. And I thought this study was very interesting. The title is Impact of Scleral Lens on Corneal Curvature and Pachymetry in Keratoconic Eyes. So this study just came out in Cornea in September of 2021, online ahead of print. So this is fresh off the press. The aim of this study was to evaluate the influence of scleral lens wear on corneal curvature and thickness in keratoconic patients. So they took corneal tomography before lens insertion, 6 hours after removal, and then the next morning. They looked at K flat, steep, and K max and Pachy. They found that there was minimum corneal flattening for all 3 curvature parameters immediately after lens removal, but it was not statistically significant. So when we look at these values, it's about a quarter diopter. In the flat K, the steep K was 0.37, and Kmax was only 0.19. And in the conclusion of this study, they actually said, you might consider having patients come in without scleral lenses to get a more accurate reading. But the values here actually tell me that scleral lens wear doesn't really change it too much. Now, if you're looking at a patient with Ks of 50, and you're seeing a variation of a quarter diopter, to be honest, you could probably even see variation like that within the same day, within a few minutes of taking that image. We know that scans don't come out identical every time you take it. Depends on tear film. If they're blinking, did they look off center a little bit? Are you now scanning through, a slightly different area? So this tells me that we're not getting too much change in the corneal curvature, even with scleral lens wear, so that you can continue to monitor, even if they come in wearing them. So in essence, there was minimal transient alteration in the anterior corneal curvature and corneal thickness after 6 hours of lens wear. So that's a pretty neat study. That's very new. So let's get back to testing our keratoconus patients in clinic. So the first thing we want to make sure we do is get their incoming VA, do confrontation testing to make sure we're not missing some huge visual field defect, evaluate the scleral lens fit and condition and the tear film before you take the lens off. So as the doctor, you need to see the lens on your patient's eye before the patient removes it. You need to see where it's tight, if there's any edge lift, what the tear film looks like, is there any clouding underneath that, underneath the lens. Once you remove the lens, you stain with fluorescein and see, is it leaving any impression around any portion of the eye where you may need to adjust the fit? Was it hard for you to remove it? Was it super tight and suctioned, or did it come off pretty easily? Look at the cornea, the conjunctiva. Also make sure to measure the IOP. It's been a hot topic recently, looking at the relationship between scleral lens wear and IOP, and some of the reported studies have shown some conflicting data, but in general, it doesn't seem that scleral lens wear causes a huge significant change in IOP in the majority of the studies, except for the ones using transpalpebral tonometry. Those studies tend to show more fluctuations and possibly an increase in IOP during lens wear, but it may actually be due to the particular piece of equipment or instrument that's being used in the first place. So again, measure the IOP to make sure we're not causing glaucoma in our patients. Do imaging with topography or tomography, whatever you have available to you, and make sure to also refract them. It's helpful for patients to have backup glasses in case of emergencies if it's functional. Typically, I use DMV driving limits to see if we can get them seeing at least in that range with glasses. If not, and they're only correctable to 2200 or 2300, sometimes those glasses don't make much of a difference at all. Then it's important to, after you take off the lens, do all your testing, rinse their ocular surface and reapply the lens and check the vision again. I find that it's hard to get a crisp, accurate over-refraction when they first present because there could be some debris, there could be some tear film issues, and I want to make sure that we have the most accurate prescription possible for our patient. So what do you decide during this examination? Well, the doctor needs to make some decisions. First of all, is your scleral lens fit acceptable? If yes, continue wear and return to clinic, whether it's 6 months or a year. And a lot of people ask, how long does a scleral lens last? I'm actually doing a study on that as we speak. I'm not finished quite yet, but in general, my impression is that patients can typically use a lens, if they take good care of it, for about 1 to 3 years. Sometimes less if they drop it and they're really rough when they scratch the lens surface, sometimes more. I've had patients wear their lenses comfortably and with great vision for 5, 6, 7, 8, and even 9 years. So it depends on the patient there. If the lens fit is not acceptable, then you need to reorder or refit them. So aside from the lens fit, you also need to make sure you're monitoring their ocular health. So is their health stable? If there's no progression, then you educate the patient and monitor and tell them that they're stable, and they'll feel good about that. If they're not stable, you then also need to educate them about what's going on, treat them, or refer for treatment. So there's also, scleral lens fits versus medical or health follow-up visits. So I just want to kind of see if we can clarify that a little bit. So when you first see your patient, if they're presenting for a scleral lens consult, that will be your first visit. Then you have following visits, subsequent visits for their training and fittings to see if you need to reorder to adjust the prescription or the fit. Once you've finalized the fit, you then need to continue follow-up to monitor their health, which could be every 3 to 6 months. And then you also need an annual comprehensive exam. Make sure to reinforce the importance of annual evaluation at least, and that, if they think, they might not come back because they're doing so well with their contacts, and that's a problem, because you again want to make sure that you can take a look at their health in addition to just the contact lens. So essentially, you're going to be seeing these patients every 6 to 12 months at least, and possibly even more for younger and higher risk patients. So what are our goals for our keratoconus patients? 3 main ones. 1, good vision. 2, good comfort with whatever modality they're using, and good ocular health. We want to make sure that we're protecting their vision, monitoring any corneal changes, and preventing progression, because ultimately we would like to avoid a corneal transplantation. There's a report that says that 12 to 20% may require a corneal transplant. However, a newer study, I didn't include here, has said that actually the rate of transplantation is going down recently, and it's partly because of these great options we have with specialty contact lenses, where patients don't need to have a transplant anymore in order to be functional with their vision. So what are some procedures to help these keratoconic patients' vision? Well, we have several. One is corneal intacs. This was FDA approved for keratoconus in 2004. It was actually approved for mild myopia treatment about 5 years prior. And these rings, these plastic rings, it can be 1 or 2 in different orientations depending on where the steepest part of the cone is. It essentially flattens the cornea and helps allow the patient to get either more functional glasses or a better contact lens fit. Now, with scleral lenses, it really doesn't matter too much, which we'll talk about in just a minute. We also have something called topography-guided PRK. Essentially, this smooths the cornea. And then we have a corneal transplantation, the most invasive form of treatment, essentially where we replace the center of the cornea, either if it's too thin or the scarring has progressed too much. So let's talk about intacs and scleral lenses first. So the goal is to improve uncorrected and spectacle corrected vision. So maybe uncorrected before they were 2800, and maybe with the intacs, because it's flattening it and making it a little bit more smooth, they can maybe see 2200 or better. So some patients are happy about this, but be aware that best corrected vision with scleral lenses may actually not improve after intacs, because the scleral lens itself essentially neutralizes the corneal irregularity. And the lens itself, you can correct it to pretty good vision these days, particularly with decentered optics, as well as correction of higher order aberrations, which are still tricky though, don't get me wrong. Be aware of glare. particularly in young patients who have large pupils. If the pupil dilates, particularly in the evenings, and hits the edge of that ring segment, it can be very disturbing and distracting and frustrating for patients who have significant glare, causes this glare. Some patients may still need vision correction after the Intacs. Some can even wear the same scleral lens. Some may end up going from a scleral lens to maybe a soft toric lens. You can also do topography guided PRK even after Intacs. You kind of smooth it out a bit, and then you even touch it up a little bit more. So let's talk about that. So topography guided PRK can be done after Intacs and cross-linking. So you want to kind of stabilize the cornea first before you try to fine tune it. The goal here is to smooth out the cornea, create a more symmetrical curvature, and ultimately improve refractive outcomes. And also this procedure, you really don't alter the tissue too much. The reduction in tissue is limited to about 45 to 50 microns. And essentially the goal is to reduce the irregular astigmatism or possibly enlarge the optical zone to help improve best corrected vision. This procedure may allow for transition from specialty contacts or sclerals to possibly standard soft contact lenses. Challenges, however, do include epithelial healing or corneal opacification. And finally, corneal transplants and scleral lenses. So this is a tough one. So uncorrected and spectacle corrected vision may improve, but you need to warn your patients that many patients after a transplant still need vision correction, and many of them may still need scleral lenses if the graft is very irregular. So some tips for scleral lens fitting in patients with transplants. Well, one, make sure to monitor their best corrected vision. You also want to check for any haze or edema. So when I see the graft for the first time without any lens, I make a note. Is it hazy? Is there any microcystic edema to begin with? Where is the neovascularization? Is the graft clear? Make a note of all the baseline findings because you need to know if you are contributing to any adverse effect. So monitor the corneal thickness. Get at least a central corneal pachymetry or tomography if you can. Consider higher DK materials. We have some great materials with DK close to 200 now. And if it helps minimize hypoxic challenges, well, let's use it. Make sure you're fully vaulting the cornea after the lens settles. We know that smaller diameter scleral lenses tend to settle a little bit more than larger diameter lenses, but all of them settle to a certain degree. So make sure that you give enough clearance so you're not hitting or rubbing the graft, and ensure that the lens is not inducing edema or contributing to graft failure. Now, I do have a lot of patients who have had a graft who continue using a drop of topical steroids such as prednisolone acetate 1% or 1 drop of Lotemax every day. And that's okay if they need that to maintain the health of their graft. Some patients are using the topical steroid even without lens wear. Just make sure that they're not using drops on top of their contact. So we've talked a lot about how we can help improve vision in our keratoconic patients. Well, your patients may also ask you, hey, doctor, is there anything I can do to help my keratoconus itself? And the answer is yes. We now have corneal cross-linking available to stabilize and slow progression. Now, I'm in the United States, and the FDA approved cross-linking in the United States in April of 2016. However, it is important to know that cross-linking has been done for about 2 decades. It started predominantly in Europe, in Dresden, Germany. This is where they kind of formed the basis of the protocol that we're using now, but it has been done for decades already. So even though it was only FDA approved in 2016 in the US, it has actually been done for a long time, and there have been a lot of reports in the literature demonstrating its efficacy. So the FDA approved version in the US is referred to as iLink, and it uses a specific system, the KXL UV system, along with a specific formulation of riboflavin. Indications are 1, progressive keratoconus, and 2, post-LASIK ectasia. The procedure involves epithelium removal, so it's epi-off, and this varies from the epi-on procedures, which are currently in the US not FDA approved. And the procedure itself takes a little bit over an hour. So there's first a 30-minute riboflavin application. Then the doctor needs to make sure there is a minimum corneal thickness of 400 microns. If it's not, you could risk causing harm to the corneal endothelium, which we don't want. After you ensure that your cornea is thick enough at least 400 microns, you then expose the cornea again for 30 minutes to 365 nanometer UVA light at a power of 3 milliwatts per centimeter squared. And during this process, the activated riboflavin and reactive oxygen species interact in the cornea to form these crosslinks and stiffens the cornea. It's been reported that there's almost a 330% increase in biomechanical rigidity, which is pretty impressive. So first, in this epi-off, FDA-approved protocol, you first have to remove the epithelium, and it's typically done in the central 9 millimeters with alcohol. You then soak the cornea with Photrexa viscous. You put the drops in every 2 minutes for 30 minutes. Then you check for flare, and this is to ensure that the entire cornea has been saturated. Once flare is observed, you want to make sure you have that minimum corneal thickness of 400 microns. And if not, you can instill drops of Photrexa, which is an agent. It's a swelling agent. So if it's not thick enough, you put those drops in and it helps the cornea swell a little bit. And typically you can get about a 70 micron swelling effect. So if your patient first started at about 330, 350, the doctor can probably get the cornea to the minimum thickness of 400 microns. And lastly, you irradiate for 30 minutes with the UV light. So just as a review here, we have our KXL system with Photrexa viscous and Photrexa. And again, Photrexa is the hypotonic agent that helps to swell the cornea if necessary, and a specific UV light delivery system. No other riboflavin solutions or UV devices can be used in the US outside of some type of study. In terms of age, well, is there an age range limitation? The answer is no. However, I do want to note that only patients aged between 14 and 65 were included in the FDA studies. So technically they didn't study, 9-year-olds or 12 or 13-year-olds, but it doesn't mean it's contraindicated. We also do not advise doing cross-linking during pregnancy just because we don't have enough information about the effects on the fetus. So these are some of the corneal specialists that I work with at USC, and this is what our cross-linking procedure room looks like. This is what the machine looks like, and the riboflavin comes in these packages, and this is where you spend about an hour performing this procedure. So in terms of cross-linking expectations, well, we need to educate our patients that this process is aimed to slow or stop progression. It's not LASIK. It's not refractive surgery. They're not going to come out of it seeing 20/20. It also will not remove scarring. So if they have already moderate or mild central scarring, they need to know that that scarring will not be removed. It's also important that we treat the dry eye to enhance healing because, again, epithelium removal is required during this process, and that they still may need visual correction after the procedure. The recovery period involves a bandaged contact lens. Yes, there may be some discomfort. Remind your patients not to rub their eyes and call if they have any sudden pain or vision decline. In terms of post-operative considerations, well, after the procedure, our patients are typically given an antibiotic, a topical steroid, and sometimes a non-steroidal anti-inflammatory drug. One of my corneal surgeons doesn't like to use it because she says that it can delay the healing response. Copious lubrication and placement of a bandaged lens for about 1 week. They use these medications on top of the lens, and at 1 week typically is the point where the epithelium has healed. If not, you may need to leave it on longer or change your protocol a little bit. At 1 month, this is typically where we assess vision. We do imaging to look for stromal remodeling and possibly consider a contact lens fit if there's no central haze and if their vision is pretty stable. I like to refract them if possible at 1 month and 2 months and see if they're pretty stable. Do the imaging and see, are they still flattening? Are they changing a bit? And make sure that the cornea has healed fully. For scleral lenses, sometimes you can fit them a little bit sooner because nothing's rubbing directly on the cornea. But for lenses such as RGPs, soft lenses, or hybrid lenses that touch the cornea, you need to ensure full healing before you put them in a contact lens. And even after the procedure, you need to assess vision with refraction, imaging at months after, and possibly just even every year, just making sure that they're stable and not progressing anymore. And of note, at least in the United States, there is a zero global period, which means that you can bill for all of these visits after cross-linking to insurance. And I love these photos here. These are actually of a patient of mine who had cross-linking after refractive surgery, LASIK. And these images were taken with an anterior segment OCT before cross-linking at the top, looks kind of smooth around, and 2 months after. So the images below, you see this very distinct demarcation line. And there is some evidence that this demarcation line could actually be a measure of effectiveness and a depth, showing the depth of the cross-linking treatment. So something is definitely happening in this procedure. And this demarcation line does tend to fade after a few months. So cross-linking, I don't go recommending this procedure blindly to all my keratoconus patients, because with every procedure, there are potential complications and they need to be aware of that. These include infection, non-healing epithelium, corneal haze that can lead to scarring that could be permanent, endothelial cell damage, or even continued progression. I've had a few patients have their cross-linking procedure repeated once, and I think one, possibly even twice, but the first procedure they had was epi-on, and some of the results can vary between epi-on and epi-off procedures. So here's an example of a 16-year-old Hispanic male who was diagnosed with keratoconus in 2018. So he was 13. He had cross-linking only in his left eye a year later. However, this resulted in diffuse persistent corneal haze and scarring. And unfortunately, even with the best fitting scleral lenses and the best, refraction I could get, he was only 20/25 minus in that left eye. And you can see his eyes here with scleral lenses on the right and left eye. And you can see this diffuse haze. And here's a close-up of it, of his left eye. Both he and his mother were so frustrated and disheartened that they chose this procedure in hopes to help him as a young individual, and now he has this permanent haze even after a couple years. So you want to make sure your candidates, they're good candidates, but still remind them that there is a very small chance of complications. And I put these here not because we're going to review these studies critically, but just to show that the efficacy of cross-linking has been well supported by literature. And this top one here, the title is Riboflavin UV Ultraviolet A Induced Collagen Cross-Linking for the Treatment of Keratoconus. And this was all the way back in 2003. Their conclusion was that cross-linking may be a new way for stopping the progression of keratoectasia in patients with keratoconus, a new way almost 2 decades ago. So this is something that has been around for a long time now. And I also want to touch upon differences between epi-off and epi-on. So epi-on cross-linking is being performed around the world by a lot of physicians. And epi-on cross-linking is also known as transepithelial procedure. And with these procedures that are not necessarily FDA approved, the protocols can vary. The riboflavin formulation or the power of the UV light, the wavelength, the time, is it pulsed, continuous light? There's a lot of variations that a lot of people are studying now. So in May of 2019, enrollment was actually completed in a phase 3 epi-on cross-linking clinical trial for progressive keratoconus. And here they used a new UV light source, supplemental oxygen with goggles, a new drug to penetrate the epithelium without having to fully debride it or remove it, and reduce treatment time. So this is very exciting. So they looked at 279 eyes at 14 US clinical sites and essentially found they achieved a prospectively defined primary efficacy outcome, demonstrating essentially a 1 diopter flattening effect in Kmax. And this is going to form the basis for a planned regulatory submission by Glaukos in 2022, next year. So maybe we will actually have FDA approved epi-on cross-linking, hopefully in the near future. So another thing I want to share is that tomography and topography interpretations are very important. If your images are not reliable, it could really throw you off as to whether the patient is having progression or not. These examples here show the same eye. They're both the right eye. The images were taken seconds apart. But as you see on the left, there's this red box because the patient was blinking. And in those results, we got a much steeper inferior cornea than when we repeated the test and it was more accurate. So I just want to highlight that. Make sure that the images that you are acquiring are reliable and consistent. And with keratoconus, particularly the more advanced you go, it's very common to have even slight fluctuations within one sitting. So take enough to make sure you have a good appreciation of what's going on in that patient's eye. And if you can't get it that day, make a note to repeat the scans again when they return. So again, some things that can lead to errors or unreliable imaging are the eyelid, blinking, fixation issues, or you're missing data. So make sure you're getting good data before making decisions. So let's go into a few keratoconic cases here. This photo is from one of my favorite patients. He's 97. I just saw him a couple weeks ago, and his cornea is one of the absolute thinnest I have ever seen. You can see in this image, I believe his corneal thickness is about 100 or possibly even thinner. He hasn't perforated. Interesting thing is his fellow eye was even thinner, and my corneal surgeon did a transplant on that eye when he was 87, and he's doing fine, both in the eye that he had the transplant and in this eye where it's very, very thin. He still sees about 20/30 or so with the scleral lens. So here's an example here that I'd like to share. This is a 15-year-old male who I saw in 2021. He presented with uncorrected vision of 2300 and 2100. His tomography is obviously very high. So 60, 53, 59, and 51. This is way steeper than the average K, which is typically in the low 40s in our patients. So I actually was able to learn a lot from my autorefractor printout. Here we learned, one, we couldn't get readings in his right eye. They were just unable to be obtained. In his left eye, the autorefractor was showing measurements of -26 and +13, which are very unusual. And look at the numbers themselves. We're seeing asymmetry within the corneas themselves. So 56, and 65, and in the left eye, 53 and 61. So we know something is going on here. I was unable to refract him to, functional vision with glasses, and it was very inconsistent. He had central striae and mild scars already. So what did I do for this patient? Number one, I referred him immediately for cross-linking. This patient had been referred to me by an outside optometrist just 2 months prior. I compared my notes to the notes from the referring provider and already saw signs of progression within those 2 months. So I knew this boy was progressing just in front of my eyes. So I sent him immediately for cross-linking. The second thing I did was I fit him in scleral lenses right away. Now, sometimes you may ask, do I do cross-linking first and let it stabilize before I do the scleral lenses, or do I do the scleral lenses and then they have to change it? In this case, this young male could not function in school. He had behavioral issues. He couldn't play baseball. His depth perception was poor. So I didn't want him to suffer visually anymore. These were his topography images. So definitely you see central thinning in the low 400s and significant steepening already. I fit him in scleral lenses. I trained him about 2 to 3 weeks after I first saw him once the lenses came in, and he saw 20/20 in each eye. And this was really remarkable for him. His mother, he was looking at his hands, he was looking at his feet. He was so excited to be able to see again. So here's another patient, a 25-year-old male with keratoconus. And so he presented in 2018 with gradually worsening blur in the right eye more than the left. When he came in, the tech refracted him, again, very unusual high asymmetric readings. He then had cross-linking done 2 months later. I then saw him a month after that, and we fit him in scleral lenses, and he saw 20/20. Now, the interesting thing is, so here's his pre-cross-linking tomographies, the right eye 55, 45, left eye 47, 44. And 2 years later, we see here that his K's actually flattened a little bit, which is typically what we expect after cross-linking. Here are his eyes, scleral lenses, again, seeing well, good comfort after his cross-linking. But I want to look at these values here, which I think are very interesting. So when he first came in to see me in 2018, again, we really struggled with the refraction and good vision in his glasses only. I just couldn't get it. His incoming vision in 2018 was 2100 and 2040. Now, in May of 2020, his uncorrected vision, which I put in red, was 2040 and 2025, so better than before. And I was actually able to refract him to 2040 in the right and 20/20 in the left. So this doesn't happen all the time with cross-linking, but sometimes as the cornea remodels and the shape changes slightly, sometimes you can get better results with a refraction in glasses. So something to keep in mind. So why do we want to make sure we can detect keratoconus and treat to prevent progression? Well, if we don't, there are a lot of complications related to advanced keratoconus. One is corneal eye drops. You can see on the left eye here some slight corneal haze, and here's a close-up of that. This patient developed corneal eye drops and has significant scarring. You can see the break in Descemet's membrane very clearly here. Best corrected vision after this incident was 2050. And one thing I do want to mention that was very interesting is she was already wearing scleral lenses pre-eye drops. She took a break for a couple months and then resumed wear in the same contact. And it turns out that the over-refraction change was only about half a diopter or 3/4, and we decided to leave it. So even after the incident of corneal eye drops, this patient was able to wear her same scleral lens. And let me just quickly explain what eye drops is. It's essentially an acute rupture in the Descemet's membrane, which allows aqueous fluid to rush into the corneal tissue. This causes swelling, haze, and inflammation. And to treat this, you need time. It will heal over time, typically in a few weeks or months. You might sometimes also concurrently prescribe a topical antibiotic to prevent infection, or even a steroid just to help with some of the inflammation, or a drop like Miro 128 that helps to kind of draw the fluid out of the cornea. So here's another patient, a young female in her 20s who developed eye drops after severe advanced keratoconus in her right eye. And even with the scleral lens, her best corrected vision is about 20/50, 20/60 in that right eye. Thankfully, she's 20/20 in the other. But again, these are complications we would prefer not to see. In terms of what we mentioned earlier about nature and nurture in keratoconus, well, I have a family, mother, son. She actually has 3 children, and one son has keratoconus much more advanced than she does. Thankfully, her other 2 children don't have it, but there's definitely a genetic component. So when you see a patient who has keratoconus, if they're young, you want to ask about their siblings or cousins or anybody else who might have high astigmatism or challenges with their vision. Maybe they have keratoconus undetected. But if you're seeing an older individual, you want to make sure they get their children screened because they could be at higher risk. In this family, the mother is a 52-year-old. She developed keratoconus at 37, had intacs, and struggled with RGPs for many years. And I eventually refit her into scleral lenses. She's doing much better. I actually just saw her a couple of weeks ago. And her son, he actually has a much more aggressive form with significant scarring. In scleral lenses, I'm only able to get him to 20/40 and 20/50, but he doesn't want to have a transplant. So at least he has comfortable lenses that give him functional vision. And we've talked about a transplant because this is the best that I can achieve with scleral lenses at this time. He has a 5-year-old daughter. So it's very important. I've stressed it to him. Make sure she has eye exams every year, and it's typically around the teens. Make sure you tell her eye doctor that her father has keratoconus because there is definitely a genetic component. So it can run in the family. So don't wait until it's too late to do something for these patients. This study here, published in July of 2019, titled A Systematic Review and Meta-Analysis of Over 11,000 Eyes, looked at the natural progression of keratoconus. Essentially, what they found was that younger patients and those with a Kmax steeper than 55 diopters at presentation have a greater risk of progression. So closer follow-up and a lower threshold for cross-linking should be adopted in patients younger than 17 and a steeper than 55 diopter Kmax. So remember, 17 years old, steeper than 55 diopter Kmax, although we would prefer not for it to get to that point already. So it's definitely better to refer for a second opinion, especially maybe if you don't have all the equipment or technology to detect early signs of keratoconus. Send it to someone else to get a second opinion or to get extra imaging or to have another set of eyes. Just look at this patient. It's better to get this further evaluation than to have to refer for a corneal transplant, because we know there can be a lot of challenges associated with a transplant. So let's talk about the importance of early keratoconus intervention. One, we as eye care providers want to preserve vision for our patients. We want them to be able to maintain their ability to wear contacts and maintain quality of life. We want to prevent progression. We don't want to see significant scarring that can reduce their best corrected vision. We can't reverse those scars once they've formed. Lastly, we need to protect against the need for surgical intervention. We know that there's complications related to a graft, potential graft rejection over time, and also the cost. Here's obviously an example of a very ectatic graft after surgery and still requires wear with contact lenses. Here is a patient of mine who had corneal transplants for keratoconus a couple decades ago. And it was interesting because both of her eyes, the fit and the grafts, they look pretty equal and symmetrical. However, this patient developed transient corneal edema in the right eye about 2 years after she started wearing her lens. So I ended up having to refit her into RGP contacts. I know it doesn't look beautiful, but believe it or not, she's doing really well with the RGP in her right eye. She ended up going back to a scleral lens in her left eye, which this combination works for her. But keep in mind that grafts don't always function the same in the same person. You need to measure eye pressure. You need to measure corneal thickness. You need to check for signs of haze or edema in each eye, and you might need to treat them with different plans. So for some of our doctors here today who are not from the United States, I wanted to provide this link here that you can find physicians that provide FDA-approved cross-linking, the current epi-off protocol through this website. So glaukos.com/INT/corneal health/patient/find a physician. So if you look on the website here, you can get more information about providers, particularly in your area, even outside of the United States. Livingwithkeratoconus.com is a really great website for your patients to learn more about keratoconus and cross-linking, and those who offer FDA-approved cross-linking compared to the current non-approved versions that are currently epi-on. And another great site I wanted to mention is the National Keratoconus Foundation. It's a great organization for patients and doctors also. There's a bunch of great webinars and educational resources for your patients. So keratoconus and cross-linking follow-up visits. So when do you do them and what do you do? So if your patients are stable, your keratoconic patients, see them once a year. If there's potential for progression, see them every 3 to 6 months. And post cross-linking, you want to follow them a little bit closer, about every 1 to 3 months until they're stable. Because at that time, if their vision's changing, you might have to recheck for their glasses or make sure that you're in a good position to refit them with contacts, and know that it might change a little bit, over the first 6 months even. But even if you start a contact lens fitting at 1 or 2 months, you know that there's typically a global period for your contact lens fittings that gives you a little wiggle room to make adjustments as needed over the next couple of months. Test and procedures include a manifest refraction, best corrected vision with both glasses and contacts, slit lamp looking at corneal thinning, striae, and scars, corneal readings with an autorefractor or a keratometer if you don't have imaging, corneal thickness with a pachymeter, or even a tomographer if you can get global pachymetry and topography. So make sure when you get these findings, you need to compare it with your previous visits to know if your patient is indeed stable or progressing, and this will help you make your decisions. So in summary, for scleral lenses and management in keratoconus, first, scleral lenses are a great option for keratoconus vision correction. Make sure to remove them on exam because the good vision and the good comfort could be potentially giving your patient, false positive hope that nothing's changing. The great vision they're achieving could possibly be masking progression. Refract them regularly. Get your K readings from your keratometer, even from your autorefractor is better than nothing. And best if you have topography or tomography to look at the mapping and the exact contour of the eye. Follow closely in younger patients and higher risk patients, those who rub their eyes, who have allergies, eczema, who have family history, every 6 months or even sooner. As I shared, I had a patient where I saw progression even within 2 months. Know that we have many surgical procedures to improve vision. We talked about Intacs, topography-guided PRK. Obviously, we don't want to have to do a transplant, but if necessary, it is available. Know that cross-linking is the only procedure to stabilize and halt progression. This is a great opportunity for us as optometrists and eye care providers to co-manage with our colleagues in ophthalmology. It's a great practice building opportunity. I've worked in the Department of Ophthalmology now for over 12 years, and we've grown to have mutual respect and trust for each other. We've become friends, and we know that each of us do certain things better. I refract and fit contacts, specialty contacts better than they do, and they're obviously surgeons, and I'm not. So we have to focus on, the stronger skills that each person has. Lastly, when in doubt about anything in your keratoconus patient, just refer out and get another opinion. Thank you so much for your attention and your time wherever you are, whether you're at home or work, whether it's morning or midday or night. Again, I'm so thankful for this opportunity to share with you today. Thankful for the Global Specialty Lens Symposium and class. This is a real treat for me to be able to connect with you. Please feel free to reach out if you should have any questions at all. I am in Los Angeles, California. This is my phone number, my email, and my Instagram, and I hope to be able to meet with you in person one day. Thank you so much and have a great day.